Good afternoon, everyone. It's Kathy Costello, and I'm very pleased to introduce my cohort in crime, Scott Mash, whom many of you know. He provides, besides color commentary to our webinars, is really a technical guru in a lot of ways. We've been really fortunate to have Scott as part of our organization because he brings with him a lot of technical capability. And today we're going to be able to pick his brain about some of that. And, hopefully when you walk away, it's not that, and my guess is that virtually everyone who's on the webinar is already in the process of using electronic health records. And I think what Scott will add is the icing to the cake to talk about how to most effectively use that so that you in turn can better manage your chronic care patients. And as you know, this webinar is sponsored in conjunction with the Ohio Department of Health and covers diabetes and hypertension care and the use of electronic health records for that. And so with that, I'm going to turn it over to Scott. And I would remind you, Scott will go through this at the end, but this is one of a series of webinars involving diabetes and hypertension management. And we have another 4 coming up involving chronic care management and the coding and other requirements to bill Medicare or other providers for that. Talking about the physician data collection that's been done around the state for quality measures for diabetes and hypertension, and the use of other technology functions for diabetes and hypertension management. And with that, over to you, Scott.
All right, just to remind everyone real quick, questions will be addressed at the end of the webinar. If you have any questions at any time, just click on the questions feature within the GoToWebinar application, enter your question. If you can't find it, enter it into the chat box. When we get to the end, we'll take the time to answer every single question. So today we're going to talk about some of the EHR functionality that you could use to manage your patients with hypertension and diabetes, and really any condition. We're going to look at the CDS rules, problem-based order sets, and patient reminders. And we are going to be talking holistically about EHRs, and regardless of which EHR you have in your practice, it can provide a valuable set of tools for managing your patients with chronic conditions such as hypertension and diabetes. The tools may have different names within your EHR, but they all have nearly the same suite of available functions. There are numerous competing priorities, so it's not uncommon that a practice installs an EHR. They kind of learn the meaningful use and other workflows. They set up an order set or two, and then they move forward. The key for success and efficiency gains with your EHR is really spending some time to receive training, browsing through your user manuals to fully understand and configure some of the higher level functionality.
Yeah, because on all these EHR systems, the certification that CMS requires and ONC requires means that every single system, no matter who the vendor is, will cover that particular type of functionality. But what you're hoping to do, and what Scott's going to give you pointers on, is that really how to refine that and make it personal and usable in a way that you're going to be comfortable with it and it provides the best care in your situation.
And later we will actually look at a couple real-world examples from some of these vendors on later slides. So meaningful use for all of its problems really did serve as a foundation for payment reform and other programs. And early on, some thought that the EHRs would be a passing fad, but the reach of healthcare information technology and EHRs is going to become more broad over the coming years. The new payment reform models and other healthcare initiatives will require reporting directly from your EHR, which in turn will require your care teams to rely more on the discrete data that's stored in your EHR and the functions for improving care built into your EHR. It is a fact that your clinical team in a practice that goes from paper to an EHR is going to notice a slowdown in the delivery of care. That's a fact. Now, it's also true that with the proper workflow redesign careful work segmentation, you can over time get your practice nearly back to 100% efficiency. There are some real advantages to having an EHR in your practice, and even greater advantages when you take the time to fully embrace your EHR, to obtain the initial training, to receive ongoing training, and to allow your entire care team to get the needed training that they need to be successful. Also, when you fully develop the various tools and functions within your EHR, you're going to see a huge return on that investment as well. This does take time from your practice, but you will experience a real payback. Now, there are definite advantages that can be realized by those that fully embrace their EHR. You know, if you've got an EHR just to avoid the meaningful use penalties, then you're probably not going to realize any real advantage.
And some of the people are actually on their second go-round with EHR systems, and so hopefully this will give you the opportunity to explore increased functionality that will make it even more advantageous to rely on the EHR functionality to get some of your chronic care management done.
Yeah, and if you do very little with the development of your EHR, one thing that you will realize still is an advantage is the expanded reporting options. You know, for example, you can perform your PQRS reporting directly from your EHR rather than via claims or chart abstraction. Some private payers offer increased reimbursement or incentives for participation in an improvement program, but that all requires reports, and those can be generated from within your EHR. Reporting in general is much, much improved when you have an EHR over paper charts, especially if you understand or take the time to learn the ad hoc reporting tools. Now, EHRs are really expensive. The costs for an EHR, you know, they include your initial software licensing, and then you've got the ongoing maintenance fees. You'll have, in many cases, consulting fees. If you do interfacing with the HIE or other systems, you're going to have interface fees. Then you have the cost to train your employees, the cost of overtime for your training and kickoff, and then your temporary loss of revenue due to the reduced schedules during an implementation and during major upgrades. It does take time and a great deal of work to realize a return on investment, but it is possible. Some of the ROI, of course, comes from the meaningful use incentives, but those incentives, let's face it, they only cover a small portion of the overall cost of owning and operating an EHR. The more time you invest in understanding your EHR and in training and workflow redesign and with developing the tools, the greater your return is going to be. You can realize real increased revenue from more accurate coding based on the more rich content that can be captured in your EHR. And perhaps you got a few cases where you could in fact be billing for a higher level of encounter where appropriate, which in turn means more, an increase in your reimbursement. The use of documentation templates and tools such as Dragon can dramatically reduce, if not completely eliminate, transcription costs. One great feature of EHRs is that care teams can be reminded of various health maintenance items. For example, if you got a patient that's overdue for a physical exam or for some lab test, or any number of items that could in turn bring in some additional revenue to your practice. You can realize an increase in productive staff time by the use of electronic prescribing. So, you can eliminate that back and forth calls with pharmacists. And also, if you use electronic referrals instead of making calls to specialists, that can save you some time. The elimination of chart abstraction for IQR, PQRS, and other reporting programs through the use of vendor-provided reports or other reporting mechanisms, sorry, can't get that word out. Then there is potential for an increased reimbursement with positive. There is the potential for an increase in reimbursement with positive value adjustments with PQRS, so your reporting. Integration of your EHR with the Ohio Department of Health for immunization reporting, so that the immunization documented in your EHR automatically flows over to the Ohio Department of Health rather than having to log into the ImpactSys system and re-enter the same information. It's going to, you're going to see an efficiency gain there. Other soft costs include the increased efficiency via job segmentation and workflow improvements, the reduction in faxing, reduction in rejections due to integration between your practice management and your EHR system, and just having a more rich data set and documentation available. Again, the Meaningful Use program was not without problems, but there are benefits that Meaningful Use did provide to those that really fully embrace the change. There was a national study done that found that 94% of physicians reported that their EHR made their patient records more readily available at the point of care, and that there was a greater breadth of data available. 88% of physicians reported that there were real clinical benefits to their patients. 75% of physicians reported that their EHR allowed them to provide higher quality patient care. Now, Meaningful Use also provided a common terminology with regard to the tool sets available within EHRs. The tool sets vary a little bit with regards to the breadth of functionality, but generally the concepts we'll talk about today can be applied to any EHR vendor because they were required to have these tools as part of their Meaningful Use certified system. And again, don't forget about incentives. Don't forget about the impact of the incentives on the adoption of the EHRs. Now, before we take a look at some of the functions in an EHR that can be used to manage patients with hypertension and diabetes, I think it's worthwhile that we review the two CQMs that we're going to focus on in this video series and as part of our work with the Ohio Department of Health. It's important to understand how the CQM measures identify patients, to place them in the numerator and denominator, and to grasp how these measures really work. Not with just these hypertension and diabetes CQMs, but really with all your CQMs. So let's take a look at the diabetes A1C measure. It's also called NQF 59, CMS 122, PQRS 1, and there's an ACO number that I didn't put on this slide, but it's the diabetes hemoglobin A1C poor control measure. This is what we call a reverse measure because you want to get a lower percentage. Lower is better on this measure, where in most cases higher is better. So what this measure looks at specifically is your patients age 18 to 75 that have diabetes on their active problem list. Then the measure will look at the discrete data stored within your EHR. It's going to look for a lab result, a result on an A1C test. If there is no A1C to be found for this patient within the performance period, then they're considered to be out of control. So no test means out of control. Now, if there is an A1C result, but it's a scanned document, the report's not going to see it. This report mechanism looks for discrete data. So a scanned document, that patient's still considered out of control. If there is an A1C result discretely in the system, then the measure evaluates if the most recent A1C is less than 9. Again, it looks at the most recent, and if they're less than 9, then they're considered to be in control. Now remember, lower is better, where most other measures, higher is better. This measure really looks at how many out of control diabetics are covered by your practice. Now onto the hypertension measure. This is the traditional higher is better, and is looking at the percentage of hypertensive patients that have their blood pressure under control. So now the way this really works is it first looks at your patients that are 18 to 85 that have hypertension on their active problem list. If those conditions are met, then it looks at the blood pressure readings recorded within your EHR. If there are no blood pressure readings recorded, then it just considers the patient to be out of control. If the most recent blood pressure is less than 140/90, then the patient is considered in control and they're included in the numerator. So with this measure, patients are positively counted when their most recent blood pressure is less than 140/90. And again, remember, higher is better with this measure. Now we're going to move on to the CDS rules and other functions within your EHR that can be leveraged to manage patients with hypertension, diabetes, and really any condition. So first, let's talk about CDS rules. And again, this is functionality common to every EHR. My personal opinion is that the clinical decision support functionality has huge potential, but many still view a CDS as a simple alert, reminder, or pop-up that signals the provider to some missing information, to enter additional data, or to a major contradiction. The clinical decision support functionality is intended to enhance or supplement care team decisions by presenting the right information to the right person at the right time. And this includes everyone in the care team, from the receptionist to the nursing from the intake through the exiting process, the entire team that works on an encounter or assists with an encounter, of course including the physician. A CDS should be thought of as a means of enhancing the visit by providing additional information or guidelines, but not a replacement for the care team's judgment. It should improve efficiency and reinforce best practice. A CDS is also a means of minimizing, if not eliminating, adverse events. If prescribing two medications that have a major contradiction, then a CDS rule should fire an intrusive alert warning of this potential issue. A CDS rule can be triggered by a single data item. So let's say a member of the care team forgot to enter the blood pressure for a patient, so a reminder pops up when, nearing the end of an encounter, pointing out this missing item. Or they can be very, very complex and rely on multiple data items. And we're going to look at a couple complex examples here in a few slides. Many CDS rules will look for missing health maintenance items so that the care team may get a pop-up if a patient's overdue for a colonoscopy, flu shot, an A1C, or a physical exam. And again, this could lead to the potential for increased reimbursement to the practice. So from a very high level, as you enter data into the EHR and the patient progresses through the visit, the entry of a data element or a missing data element may trigger a CDS rule to fire. The CDS rule will require some action, even if the action is something as simple as clicking on an OK button. The response to that CDS rule could in fact cause another CDS rule to fire, or the continued entry of data throughout the visit or throughout the encounter may cause additional CDS rules to fire as well. Now, a CDS rule is not a replacement for the training and knowledge of your care team. It is a supplemental tool only, so don't turn your laptop around to the patient and say, "Yeah, let's see what the computer says." Don't do that. Now, I'm going to tell you up front, the best single resource regarding CDS rules comes from HIMSS, and that's where I got a lot of the information on this slide and some of the information I've used throughout this presentation. The keys to successful and useful CDS development is to make CDS rules that are actionable in that the pop-up or reminder suggests an action. For example, a missing lab test should trigger a CDS rule saying to schedule the patient for a lab test or to provide educational information to the patient on why obtaining that missing lab test is so important to their care. It should be visible, meaning that the visual cue should jump out at you so as not to be missed, whether it's red text, a pop-up, or some other means of catching your eye. The CDS rule should be consistent such that it utilizes the data within the system and provides the notification or information by the same means so that your care team knows what to look for, and so they can be incorporated into your training as well. A CDS should be flexible so that it allows for some variance from the prescribed guidelines so that it can be made to fit your particular practice, and that there is a means of updating the CDS as treatment guidelines are changed or advanced. A CDS rule needs to be reliable, meaning that you can count on it to identify critical items that are missed without creating so many false positives that the warnings are ignored. Now, my practical advice for developing CDS rules is think about your worst and busiest day. Think about sometime when you were sick, you'd taken a cold medicine just to get through the day, you were triple booked and had way too many patients on the schedule. What did you almost miss that day? What did you overlook? What did that new person on your care team forget to ask or provide a patient? This should serve as guidance, the most basic guidance for developing your CDS rules and for building CDS rules that reinforce best practice for different disease states. CDS rules can be triggered by pretty much any data item within your EHR, including demographic information, family history, problems, meds, vitals, lab results, and don't limit your CDS rules to present to just the physician. They should present to everyone in the care team and even present outside of the patient encounter. So if your billing team, your reception team, as they're scheduling patients for their next visit or reviewing charts, CDS rules should fire where appropriate. Now let's take a look at some potential CDS rules that you may already have in your system and that I've seen in other EHRs. For example, a patient that has diabetes on their active problem list and is overdue for an A1C test, you should get an alert to the care team that the patient needs to be contacted about scheduling the A1C test, or if the patient's in front of you, that alert should have a button to where you can just click and place that order. A patient not identified as hypertensive. There is no active hypertension on the problem list, but they have 2 blood pressure readings in the last year that were above 140/90. They're undiagnosed hypertensive or potentially a undiagnosed hypertension. The CDS alert should fire to alert the physician to the abnormal blood pressure history so that they can take an additional reading, or maybe even consider putting an appropriate treatment plan in place, or identifying that patient as a hypertensive. So let's say a patient's been identified as a tobacco user, but there's no cessation counseling documented in the EHR. Well, a CDS should trigger a reminder to the physician to do that cessation counseling, or refer them to a support program. Now let's take a look at a couple real-world examples of CDS rules from several different EHR vendors. Now in these examples, I've eliminated any reference to the EHR vendor and to patient information. These slides are really just intended to plant a seed as to the potential for what you could do within your own EHR. Now the first example is the most basic form of the CDS rule, the drug-drug or drug allergy interaction checking that is built into every single certified EHR. Now this is a really good example of a CDS because it has a visual cue of the big red text. It then describes the issue triggering the alert within the main part of the window, and then finally it requires the individual who received this alert to perform some action by either modifying, canceling, or overriding the order. And also you'll see at the bottom it provides a button to the evidence supporting this alert. This is a very well designed, developed CDS rule. The next example is a CDS rule that alerts the care team to overdue health maintenance items based on the active problems on the patient's problem list and other missing data elements. Now this example is from a test patient. We all know in the EHRs, your test patients are the most sick patients you'll ever see. They've got every condition, had every test. So the number of items here is probably more than you're going to see in the real world. Then again, if you have an elderly patient who has multiple conditions, you could have a pretty extensive list of missing health maintenance items. And again, this is another very well-developed CDS. You'll see that it says past due in red, so it pulls your eye to it. It jumps out. It shows the missing item or the required item that it's looking for. And then actually out clear to the right, that options button will actually link you to an order for that overdue item. So you get all the information you need right here to know what's missing, why it's missing, how often it should be scheduled, and link you to the ability to resolve that item. Now this is another example of a CDS really built to identify missing health maintenance items, but this EHR vendor calls it disease management. Again, it shows the missing item, the missing orderable item, the last time it was performed or documented within the system, and the next time it's due. Clear out to the right, those little interlocking rings actually links you to an order for that missing item. You also see that there is a little box here that says CDS. Like for colonoscopy, you'll go out a little bit to the right and it says CDS next to unknown, and that's actually a link to a clinical guideline. Our next example of a CDS rule is actually a clinical guideline. It kind of shows you how this vendor, it's the same vendor as in the previous screenshot, but it shows you how they built CDS functionality right into the problem screen. You'll see on the next to the word problem, you'll see where there's an orange box that says CDS and a red box that says disease management. If you click on that CDS icon, it will take the care team member to a clinical guideline for diabetes. That red DM means that this patient has missing disease management items. They have missing health maintenance items that need to be addressed as well. Most EHRs do come with some pre-developed or delivered CDS rules. Most vendors will provide a means of modifying those delivered rules or for developing new CDS rules. Some providers will give you a complex rules engine on which you can build some pretty extensive and complex rule sets for your CDS rules. There are some great CDS resources available for free. I provided a few links here that I feel are the best. That HIMSS resource at the top, by far and away the best single resource you will find. But take the time to kind of review all of these because they each have a little nugget, some useful little piece of information or something, again, that's going to trigger a new thought with you on a CDS rule that could help your practice or help drive quality. And again, think of your CDS rules in relation to the various quality measures, to your CQMs. Develop your CDS rules to help you in your practice improve on each of the CQMs that you report for PQRS, IQR. If you're a member of an ACO, your CDS rule should reinforce best practice. Now we're going to change our focus for a second and talk about problem-based order sets. Now, under the Meaningful Use program, order sets, problem-based order sets are considered another form of CDS rules for meaningful use reporting purposes. Now, the reality is that problem-based order sets are very different from traditional CDS rules, but they can have the same positive impact on your practice. Before EHRs were adopted, many hospitals or physician practices would have a binder of forms or checklists that they use for different patient conditions. Well, really all a problem-based order set is taking those old checklists and making them electronic within your health record. Some vendors or practices will also use the terminology of evidence-based order sets, pretty much the same thing as a problem-based order set. And really, these are nothing more than a shortcut or a logical grouping of pre-established orderable items that are common for a specific diagnosis. In many cases, they look like the old forms where a physician can just click on an item that should be ordered and hit, or items, and then hit submit. EHR vendors may call these shortcuts or favorites. They may apply to all of the users within an EHR, or they may only apply to a single user. So they might be very specific to a single physician or a group of physicians. There are some real benefits that can be realized from utilizing problem-based order sets. Perhaps the biggest benefit, though not listed on this slide, is that it can make the ordering process much more efficient. Rather than having to go through numerous clicks, searching for different tests on the most commonly ordered tests, medications, or patient education, and other order of items, you can just select them in a few clicks and hit submit. Order sets can also reinforce best practice and treatment guidelines in that they make it easy to order the most recommended items. Many times you can develop an order set such that it supplements or flows to the clinic notes so that an order set can enhance the physician documentation or the encounter documentation, along with reducing the variation by which a practice treats different disease states. Order sets can improve a patient's care and satisfaction by making it easy to order all the needed items at one time, thereby reducing incomplete or inconsistent orders so that, you should be able to eliminate those occurrences when a patient goes home and say, oh, wait a minute, I forgot to tell Betty her A1C's due. So, for example, you may have a hypertensive order set that contains a list of the medications normally used to treat hypertension, and you can list those by type so that all the beta blockers are grouped together and all the diuretics are grouped together and so on. Then you may have a list of commonly ordered items for someone with hypertension, like an ECG or a lab test such as a lipid profile. Many order sets allow for patient education to be included so that they can be easily printed and provided to the patient. And referrals can also be included in some order sets so that you may include a referral to a hypertension education program within your hypertension order set. And order sets can potentially include many other items that aren't included in this specific example. Another great thing with problem-based order sets, and not only problem-based but all electronic order sets, is that indecipherable handwriting is obsolete. You know, it eliminates the potential for the wrong test being ordered, or rephrase that, saying it eliminates the non-intended test from being ordered. So now let's take look at a couple real-world examples of problem sets from different EHR vendors and how they lay things out. Now I'm going to say some of these next slides can be a little hard to read because there's a lot of information that we're putting on some of these slides. Things can be a little bit blurry, but you know, these examples may be of use. So in this specific example, the provider selected congestive heart failure, you'll see at the top of the window. Then in the lower two-thirds of the window, they are presented with the lab tests all grouped together that are commonly ordered, the diagnostic tests, referrals, and then over on the right side, the common meds that are prescribed, office procedures that are performed, and patient education that is generally provided. So in this example, the provider could select a few labs, a diagnostic test, a couple of the meds, and then hit OK rather than having to browse around in the EHR, find all these common sets. It just saves so much time for the physician and for the entire care team. This is an example from another vendor. It can be a bit hard to read, but in this example, the provider selected hypertension unspecified. Then you can see that under the lab orders and diagnostic tests, office procedures are all of the things that this practice commonly used to treat patients with hypertension. They can just click through and hit place order at the bottom. All of the items get ordered and linked to the appropriate diagnosis. And that's a key. That's a key to some of your billing, is that the orderable items be linked to the correct diagnosis. And you can see in this example, this patient has 3 different diagnoses or conditions listed that the provider can first select all of the hypertension, then he can select the diabetes diagnosis and be presented with the diabetes specific shortcuts. So it saves a lot of clicks and again reinforces best practice. In this example, which is another hypertension order set, it shows how the medications commonly used to treat hypertension can be grouped by specific type. So you can see here that we have the diuretics, the beta blockers, and the ACE inhibitors. And I'm sure if we scroll down, there would be the other meds and the other orderable items, the tests, the education, the referrals, all of that would be shown just by scrolling down. Of course, this being a screenshot, I can't scroll down to show you that. There's some other information there at the top that has to be entered as well. You can see also at the very top where it says all RX orders, instructions, or referrals. By selecting all, it's going to show you all of the orderable items within this order set. If we were to click RX, it would show just the meds, and so on and so on. Last item we're going to look at today is the importance of utilizing patient reminders in the management of patients with hypertension and diabetes, along with all the other conditions. So patient reminder is not just a reminder of an upcoming appointment, but a means of engaging a patient in their care. It allows practices to remind patients by text, by a phone call or by a message to the patient portal about an upcoming appointment, or about missing preventative care items, such as an overdue A1C test, to come in and get their flu shot, that they're overdue for a physical exam. It does improve the management of your patient population, such that a practice can improve the health and healthcare of all of their patients. You can also, within many EHR, set up automated patient alerts that are sent prior to appointments, and you will find that these appointment reminders will reduce your no-shows, and this, by reducing your no-shows, links back to increased revenue by maintaining your full schedule and also by getting patients in for those missing clinical items. So we're going to take a look real quick at a couple real-world examples from EHR vendors, different EHR vendors, about how they trigger these reminders and how they work and how complex you can get with some of them. Now, this is a very simple patient reminder. Some EHRs do allow for a manual phone call reminder to be logged as part of the patient record. Now, you may ask why you would want to take the time to document a call, but just think in terms of risk management with your out-of-control patients. Some EHRs allow for the patient reminder to be pushed for the portal, and I place a lot of value in this type of reminder because if you can get your patient used to looking over at your patient portal, then there's a good chance that they're going to look at their other data that's available in the patient portal, such as tests, notes, or whatever information you make available, and then in turn will become more engaged in their care. Then you can leverage your patient portal to push more educational material and any other means of keeping your patient engaged between visits. Well, some EHRs have a very complex engine for developing a patient reminder. And in this specific example, a reminder is going to be generated for your female patients to obtain a needed mammogram. But it will only generate the reminder for those patients that are over the age of 50, or in cases where the patient is over the age of 35 with a family history of breast cancer, but for patients less than 75, and if they haven't had a mammogram in less than 2 years. So as you can see, that this patient reminder engine goes back to the discrete data that is collected as part of your normal patient encounter. The same is true as your CDS. The same is true as your of your problem-based order sets. So that capture of discrete data on the front end drives functionality throughout the patient encounter and throughout the use of your EHR. So with this example, think about how you could generate a reminder or at least a list of your diabetic patients that are overdue for an A1C test, overdue for a foot exam, haven't gotten their eye exam, your hypertensive patients that are overdue for a physical exam, or they need to get a lipid profile. There's so much potential in this patient reminder tool, or this engine that's presented here. Some EHRs will deliver a suite of patient reminders pre-built or allow for a reminder that's developed within the practice to be saved so they can just simply be used time and time again. With this specific example and the specific vendor, you could click on the diabetes A1C report that's highlighted. What this does is it sends a reminder to all of the diabetic patients in your practice that are overdue for an A1C test that says, hey, come get your A1C test. This example, actually, the way this one's built in the back end is if the patient has a portal account, it pushes that to the portal. If they don't have a portal account, then it then defaults to their selected means of communication. This EHR has an automated call tool that will then, for the patients it doesn't push to the portal, it'll do an automated call send. You're overdue for your A1C, call the office and get this scheduled. So that's really the last of the functionality we're going to cover today. My intent is to create, maybe in the future we'll do another webinar covering some other functionality. But let's take a look at some of the other upcoming webinars that we have scheduled for the future. Some of the first 4 that we really have is coding and other requirements for chronic care and transitional care management programs. That will be Tuesday, June 14th from noon to 1. Now on June 28th, we had something slotted, but we kind of thought better of it, so we're kind of kicking around a few potential topics. If there's something that you would like to see that is specific to hypertension and diabetes, or you have some suggestion, by all means email us. But we're kicking around a few items, and we'll notify everybody once we settle on something. Yeah, tell us in the evaluation what you would like to see from us, and maybe we can set something up. Then on July 19th, we're going to do a webinar comparing the 2014 and 2015 physician data that we collected around hypertension and diabetes. Specifically, we're going to be looking at those two CQMs that we spoke about earlier, NQF59 and NQF18, and how providers either improved or declined over these two reporting periods. And then we're going to talk about using technology to support patients with chronic care conditions. Doesn't have to be painful. Again, that one's going to be focused on using your EHR functionality for patients with multiple chronic conditions, linking it kind of into chronic care management, transitional care management, and management of diabetes and hypertension. There's a lot more we have scheduled. Go to CliniSync.org for more info. Sign up for Dottie's newsletter. We send out a lot of webinar information in Dottie's newsletter. Now, we are still actively collecting data from organizations, from physicians from 2014 and 2015 around those two CQMs or some other EHR data we want to collect. If we've not contacted your organization, or you don't think we have, email us, let us know. We'd love to get your data. The data we take, we de-identify, we report it up to ODH and CDC at the county level. So by all means, your practice is not going to be in any way, shape, or form singled out, or really be able to get back to your practice to identify that data came to your practice. With that, let's open it up for questions, and give me a second here and I'll pull up my questions in my chat box. There's no questions that have been submitted. So if you have a question, go ahead and enter it now, chat box or question box. And while we're doing that, while I'm waiting on those, if you do have any questions about Ohio's programs that are out there right now, the resources that are available for fighting chronic disease that can be made available to your practice or maybe even to your patients, contact the folks from the Ohio Department of Health, Barb Pryor, Michelle Shaw, Ree Richmond, or you can contact me, Scott Mash, Kathy Costello, or Kathy Rich at CliniSync, and we'll get you in touch with those resources. A recording of this webinar will be made available on the CliniSync YouTube channel. Give me a few days to get it edited and uploaded, but we'll get it there. The slides, I believe the slides were sent out to everybody. If you did not receive them, let us know. We'll get you a copy of the slides. This is actually our second in the series. The first webinar is posted on the CliniSync YouTube channel. Again, if you want that slide deck, let me know. I did write an article on the use of higher level EHR functions that really served as the source of information for this webinar. If you'd like a copy of that article, email us, let us know. We'll get you a copy of that article as well. But our goal is to have an article and a webinar for the next couple months. We're going to have quite a few. So with that, I've not received any questions. So what we're going to do is we're going to give you a few minutes of your day back. Thank you so much for attending this webinar. Please take the time to fill out the survey. Let us know where we could do better, what you would like to see, what you thought was useful, so that way we can improve future webinars. Thank you so much for attending.